ICL is an interesting surgery, and we've talked about this before on other videos, so if you haven't seen ICL, take a look at those videos. But one question that comes up a lot is, what if I develop a cataract and I have an ICL in my eye? How is that handled? And this is going to show an exact case of cataract surgery where the first step is going to be removal of the ICL prior to doing the actual cataract surgery.
This is a fairly young patient, and as you can note or compare with previous videos, this is a patient who did not have the newer EVO lens, so it's still an iridotomy superiorly, and there's no central openings, so the risk of cataract development is higher. I also liked how you said, what if I develop a cataract? I usually think when I develop a cataract, because most people do. There's viscoelastic being placed behind the lens that kind of lifts it up away from the lens, and the most difficult part during ICL surgery is not touching the lens. Here, the lens, or at least the contents, will be removed.
It's ready to be removed anyways. Would you say most of the manipulation of the ICL is done with that visco, or a combination also with actual manipulation with your instruments there as well?
Combination of both. As you can tell, I check the pressure because I don't want to overinflate the eye, because that would make not sense, because it would push the ICL back. So I want to place some viscoelastic behind, make sure that I have protection against the endothelium, and then I use this instrument called a Coquelin hook to move the little haptics, or little plate, little feet, if you will, in front of the iris. This comes out fairly easily.
Now this, of course, is a patient that we mentioned has cataract and is already going to have cataract surgery immediately after this procedure. If it was a patient that you were removing ICL on who was not going to have cataract surgery, would that change the approach to removing the ICL?
The approach would probably be similar, but you would probably see me be much more nervous, and I would, in that case, most likely use only viscoelastic and just the blood cannula to move it out. I would definitely not be touching the ICL with the blade, as you just saw.
And I know a common question is, and maybe we don't always know the answer, but this patient had bilateral ICL. In this case, only one eye had a cataract. Can we blame the ICL? Was it the ICL's fault they developed a cataract? Was it just what was going to happen anyways? Do we know?
I don't know. Based on what the cataract looks, I do think it's a cataract associated with ICLs, because it's an anterior cortical cataract that you can see here. This, by the way, is the ICL loading forceps that we used to use previously to get the lens into another version of the injector. Here I basically grasp the ICL, and then I use another instrument as the ICL folds to protect the endothelium. There's quite a bit of tension, but the ICL folds up once I grab it appropriately and comes out of the main opening, usually in one piece.
And it's nice to, if you watch back at any videos of the insertion of the ICL, when it's inserted, it's rolled into a very tight space, and that same thing now we're watching, it's going to pull through a very small incision, and that material is going to collapse in on itself very nicely and just pull through. But this is the manipulation inside the anterior chamber, just getting it prepared to remove out of the anterior chamber.
And as you can tell, this is the hardest part, and getting the ICL just in the right position into the jaws of the forceps is the toughest part. So I get an appropriate purchase without ripping the ICL, but with having enough in my forceps to actually pull it out. Here it folds up, rolls up, gets into a very small, tight space through that main opening. You can see how I kind of fold it, and then once it's rolled up, it gets removed fairly easily.
That cornea sure is tough, isn't it? I mean, I was watching that thinking, is it going to widen out that incision? But the cornea remained pretty strong there. The very next part goes right into the cataract surgery. We have this sped up to about 4x speed, first with a capsulorhexis, and then separating some of the elements of that cataract with some visco.
We figured you've seen this before. This is a softer lens, so even though I use a pre-chopper that I usually do, this lens splits fairly easily, and usually just requires no phacoemulsification, no phacoenergy, which is that little vibrating of the tip to remove. This is all suction, so the damage or the injury or this trauma to the eye is fairly minimal from the phaco portion of the procedure. You saw there was still some nucleosclerotic parts of the cataract. This is removing the epicortex, again, just with irrigation and aspiration.
And when you talk about phaco, what actually is happening with the phaco device?
So the phaco, the tip, it goes sideways and vibrates almost like a little jackhammer. This is now irrigation aspiration, and I think we'll have some other cataract videos as well where we discuss the procedure more in detail. But it's a vibration that breaks up the lens, emulsifies it so that it can be removed from the eye with aspiration, meaning just a little suction, and at the same time replacing it with irrigation on the side ports.
In a moment, we're going to see something interesting happen with the iris, and it's important to remember that to get the ICL out in the first place, the incision was fairly large, and the iris already started making some pulling motions towards the wound itself, and we're going to see afterwards how the iris is actually going to prolapse out. But before that, this is the actual insertion of the lens implant into the eye.
And fairly large means around 3 millimeters, both for the insertion and removal. It's 3 millimeters. This three-piece lens, which is a light adjustable lens, also goes through about a 2.75, 3 millimeter incision. Thus, it's always a little bit larger than what we use for a one-piece, which is around 2.4 millimeters. It's just placing that three-piece, removing the viscoelastic, but you can see there's more leakage around or through the wound that we usually see during aeration aspiration, and which means that the iris might, as you can see, come forward as well.
And that is not normally comfortable for the patient when that happens, but can be quickly remedied where that iris is placed back in its position.
The key is here not to just push the iris back, but to decrease the pressure inside the eye. Otherwise, the pressure gradient will still continue to push the iris outside of the eye.
And this is just the corneal wounds being sealed, being hydrated, so that nothing can change with the iris anymore, and that anterior chamber can be completely sealed and blocked off.
You can see there's some swelling already. This patient had some chemosis, some conjunctival chalasis, and then upon injection of the medication at the end of the procedure, that is more prominent.
What was interesting for this portion was after the steroid was injected, there's that chemosis that you even see where the patient has a hard time actually closing their eyes, but that does subside fairly quickly.
Usually within a few hours that fluid is absorbed, and as long as the lid can close over, there's no issues. But sometimes it can be so prominent that if you're not careful, the conjunctiva is almost stuck between the eyelids, so then some ointment is placed to make sure that the patient can comfortably close the eyes.
So a great case of ICL being removed, followed by cataract surgery.